Without further ado, I'd like to introduce you to our presenter for this evening, Dr. Nigel Kirkham. Dr. Nigel is a consultant dermatologist, and he's got a wealth of experience in the field, having worked for a number of large hospitals and clinics in the UK and UAE. He's also been the director of pathology at a large multinational clinical research company in Scotland. So Dr. Nigel, I'll pass over to you and we can begin this evening's webinar. Thank you.
Thanks, Laura, and welcome everybody. This webinar, I'm showing you a slide seminar. I've put together half a dozen cases that I reported in the days shortly before the idea for this webinar came. So I think some of you are pathologists and will know exactly what you're looking at, and some of you aren't. So to begin with, I'm just going to say a few words about the skin. And here on the screen, we've got a rather random piece of skin, and it shows the epidermis and the dermis. And in the cases that we're going to be looking at tonight, it's called interface dermatitis because we're interested at the interface between the dermis and the epidermis in many of the cases. So here at the top, we can see what's called the normal basket weave keratin, and that's what normal skin looks like. And one of the first things that happens when skin gets inflamed or diseased is that disappears and gets replaced by more dense keratin. So here, for example, is a bit of scale. Beneath that, there's a blue line, which is called the granular cell layer, and then there's the epidermis. And this is a relatively normal piece of epidermis. We'll see different kinds in the cases as we go along, but if you just bear in mind how big that is and what it looks like, it's got a sort of rounded basal layer, and then beneath that there's the pink stroma of the dermis. Here we've got blood vessels in the superficial dermal plexus, and then the dots everywhere are mainly lymphocytes. This section also has some brown cells, and these are melanophages, macrophages that have taken up melanin as a result of something that's happened. We can see one or two other things. Some of the cells here have got clear spaces around them, white areas, so that's something we might look out for. And so let's have a look at the first case. So this was a biopsy from a 58-year-old woman who had a 2-month history of a rash on her pressure areas with oval to pinkish lesions that were hyperpigmented in the center, and then over time the lesions disappeared, leaving dark brown pigmentation. And this is the biopsy. At this point, I'm going to swap out of the PowerPoint and go to the digital slides that you had to look at. And here is that slide, case 1. And I hope you've all had a chance to go to the website and look at the slides. If you haven't already, then you can look at them afterwards. The slides will be available for some time. So here we can see, compared to the normal piece of skin that I'm just showing you, we haven't really got the basket weave keratin here. It's much denser and it's thicker, so we call that hyperkeratosis. The granular cell layer isn't a thin blue line you can hardly see, but it's quite thick here. So that's an increase of the granular cell layer. And the basal layer of the epidermis, instead of being very rounded, has got rather angulated. You know, a lot of pathological terms are very imaginative, and this is described as looking like a saw that you might use for sawing up a piece of wood, sawtooth profile to the basal layer. This is also showing some clearing of cells here, and then in the dermis, there's some melanophages and some lymphocytes. I'll just go back a little bit so we can see that. So I think this biopsy has been taken from a lesion. This will probably be a 4mm punch biopsy, and I think maybe there and there we've got 2 raised papular lesions with this kind of sawtooth appearance to the base, and it's all very superficial. You can see the blue blush of the lymphocytic infiltration. It's in a kind of band in the superficial dermis, and we come down to the superficial vessels here. There's not so many blue cells around them, and down in the deep dermis it's all pink because that's completely uninvolved in the inflammatory process. Right, I'll now return to the PowerPoint. So the features present in this biopsy are that there's a thick layer of keratin, hyperkeratosis. There's a thickened granular layer, hypergranulosis. There's a sawtooth profile to the basal layer. There's an interface dermatitis. We didn't see civet bodies, but I've got a photograph to show you that. One of the features I looked for and didn't find was the presence of eosinophils in the dermis. And the deep dermis is normal. Eosinophils we look out for because there's a differential diagnosis here, and that would include perhaps allergic conditions maybe, or lichenoid drug eruptions. And if you're lucky in those, you might start to see some eosinophils as part of a kind of allergic reaction. So here we saw the appearances of the biopsy with the hypergranulosis, hyperkeratosis, the sawtooth profile, some interface lymphocytes and a band of lymphocytic infiltration, including melanocytes with the melanophages. This is because normally brown melanin pigment is in the basal layer of the epidermis, and if anything happens to those basal cells, then the pigment is lost from the basal cells and is taken up by the macrophages. And we were told that as these lesions regressed, the skin left behind was hyperpigmented, browner than usual. And the reason for that is that the pigment is taken up in these cells and they become concentrated and make the skin look darker. And of course, one of the constant problems with people's skin is that they don't want it to be a different color. And it can be quite a problem if your skin becomes darker or lighter as a result of disease and doesn't go back to normal again. We can also see in this photograph in the center there are some pink things, and I think these are they contain abnormal keratin, the word dyskeratosis. So these are probably basal cells that have become damaged by lymphocytic attack. See, lymphocytes are coming in and going around some of these cells, and these are probably the remains of dead cells, and those are the civet bodies that are part of the thing to look for in this. So the differential diagnosis I offered you is here, and this is your opportunity to vote. So Laura, can we have the poll? Is that it ready now on the right-hand side of the screen?
You should be able to see it.
So to the top right of the screen, I think you can see the poll. If you click on your selected diagnosis, so pityriasis rosea, pityriasis lichenoides chronica, lichen planus, eczema, or mycosis fungoides. Vote now. You can only vote once, I think. Is anybody voting? I can't see.
Quite a few votes in so far. 77% of people thought it was lichen planus.
Can we see the results on the screen, Laura, or not?
Yes, you can see them on the Demio platform screen.
Can everybody else see them?
Yes.
Oh, I can't. So people, I think 13 people sent their answers in beforehand, and nobody voted for eczema, and people voted for some of the other things. And what are the numbers tonight?
So we've got 8% for the first option, 8% for the second, 77% for the third, and then 8% for eczema, and no one voted for the final choice.
Fantastic. So my diagnosis was lichen planus as well. So we're doing quite well so far, aren't we? So let's try the second case. So this is different. It's also kind of lichenoid, but different. So this was a 50-year-old man, and a photograph of his arm, I think. And he had been ill for a while and had developed these, his whole body was covered in these things. And there was a wide clinical differential diagnosis. And So show you the slide. The slide's upside down, unfortunately, but it's quite different. It's lichenoid in the same way as the first slide, but there's much more going on here. You can see the whole base of the epidermis is obscured by a dense infiltrate. And we look at the epidermis, you can see it's got a thick layer of keratin on the surface, and in this case the nuclei are still present in the keratin, so that becomes parakeratotic hyperkeratosis. We can also see these dead cells, dyskeratotic cells, and there are lots of those. And this is one of the things, in normal lichen planus, you often struggle to find these things, but in things like lichenoid drug eruptions and this condition, there are lots of them. I wasn't aware until recently that you can see them in bullous pemphigoids sometimes. We had a case in a child. So you can see here that there's a lot more going on here. There's a very dense infiltrate with lots of melanophages, lots of these dyskeratotic cells, and the infiltrate is mixed, as well as lots of melanophages. There are lymphocytes, macrophages, and here and there plasma cells, and I think eosinophils as well. So this is very pleomorphic infiltrate. If we just go back to low power, you can see how extensive this infiltrate is. Initially, the clinical suspicion was that this was going to be a cutaneous lymphoma. So I'll go back to the presentation now. And so this lesion has got a very florid lichenoid interface dermatitis, and it shows hyperkeratotic scaling, lots of dyskeratosis, very heavy superficial band of infiltration with eosinophils and plasma cells. And that shows you again what we just looked at. Immunofluorescence was done on frozen sections of a separate biopsy, and this found some focal intercellular IgG, as well as some IgG and C3 and IgM in the basement membrane with IgA negative. Thank Dr. Reen for that information. So we had a wide differential diagnosis here, so vote for your favored diagnosis, please. How are we doing, Laura?
We've got a few answers in so far. Just give them a couple more minutes. There's a few more that responded last time.
Yeah. So your choices are cutaneous Hodgkin's disease, lymphomatoid papulosis, cutaneous lupus vulgaris, cutaneous lymphoma, or something else.
Okay, we've currently got a split. Oh no, it's just changed. So number 2 is the most popular with 38% of the vote. Oh, it's just gone up to 43%. We had 4 answers for other diagnosis and 4 answers for cutaneous lupus, and then just the one for Hodgkin's.
Good. Well, I think this was a very difficult diagnosis. A very difficult biopsy, and I think the correct diagnosis is something else, because this turned out to be Paraneoplastic Pemphigus, which is something you don't see every day. Paraneoplastic Pemphigus is when you get the skin condition in association with underlying malignancy. A variety of primary carcinomas and various other tumors have been associated with this, including small cell carcinoma, the bronchus. We don't actually know the final diagnosis here, because very sadly this patient has died of disease. Paraneoplastic pemphigus is said to have about a 90% mortality, and this patient sadly fits into that category. He developed hypernatremia and various other abnormalities, suggesting that there perhaps was an underlying tumor, but it was not discovered. So we don't know the final diagnosis here, but I think the message is that this was something that looked pretty weird. There was an awful lot of disease present in the biopsy. I haven't shown you the immunohistochemistry that we did, but we did extensive immunohistochemistry on this to consider the possibility of lymphoma. And really what we saw that this was a pleomorphic infiltrate. It wasn't anything like a monomorphic T cell or B cell lymphoma. It wasn't Hodgkin's disease. Primary cutaneous Hodgkin's disease is vanishingly rare. Lymphomatoid papulosis was something that was considered. And as you know, that's a very complicated area that I'm not going to go into in detail just now, perhaps on another occasion. There are now many subtypes of lymphomatoid papulosis with different clinical presentations. Nobody went for lupus vulgaris, which is quite understandable because it doesn't show any granulomas or anything like that. And lymphoma was really excluded by looking at the immunohistochemistry in detail. And ultimately, this case is still a little bit open because we don't know what the underlying malignancy was. Not everybody with paraneoplastic pemphigus is found to have an underlying tumor, apparently. I feel that this patient must have had one somewhere, it just wasn't found. And I think it emphasizes that when you see a skin biopsy that's got lots of stuff going on, you probably need to be thinking this is a cutaneous manifestation of systemic disease rather than just some skin rash that you can't quite diagnose. 38-year-old woman with long-standing skin rash. I'll show you that section. So here we've got this skin biopsy. I think this is a beautiful example for you to see. It's got some little bit of hyperkeratosis, but that's not the main feature. The main feature is the cellular infiltrate. Deeper down, there's not very much. So there's a superficial infiltrate, and it's quite easy to see these very prominent, dark, large, variably shaped lymphocytes that are infiltrating the epidermis. So this is true epidermotropism. A normal lymphocyte's probably about something like that, and you can see these are enlarged. They've got a variable shape. Some of them are tagged to the base of the epidermis, and others are infiltrating into the epidermal epithelium itself. It's that quite nicely here. I don't think there are actually any Potrier's abscesses here, but this is clearly a pleomorphic epidermotrophic infiltrate. And so we'll just go to the next slide. So it was kind of interface. There was some hyperkeratosis. There was focally dyskeratosis. There was, oh no, it's the wrong slide. There we go. Features here were the superficial infiltrate tagging to the basal layer, epidermotropism, and an enlarged and pleomorphic lymphocytes with that appearance. Did some immunohistochemistry, and the large lymphocytes were positive with CD2, 3, 4, and 5, but negative for CD7, and negative for CD30, and I haven't said that, but essentially negative for CD8, and the proliferative index was around about 20%. Here's a photograph of the CD4, in which you can see the infiltrate and also the cells tagging the bottom of the epidermis as well as the cells within the epidermis. And here we've got the positive CD4 on the left, and in the middle CD7, which doesn't show the cells infiltrating the epidermis, and similarly CD8. There are 1 or 2 positive cells in the dermis, but the epidermotropic component is negative for CD8. So vote now for your diagnosis, please.
See the live poll vote, you need to click the polls tab on the right hand side. Sorry, we should have mentioned that at the start of the webinar, but you should all be able to see the votes as they're going in.
Yes, I can't. You have to tell me. Got some votes now?
The first answer has received 13 votes, which is 81% of the total.
Yep, good. So I thought you'd like to see this because it's one of the best examples of mycosis fungoides that I've seen in a good while. The story was that this patient had had a diagnosis of mycosis fungoides made some years previously somewhere else and had turned up in the UAE for further management. And so this was a kind of re-diagnosis biopsy. There wasn't much question about the underlying diagnosis. So that perhaps explains why it was such a straightforward diagnosis, because those of you who report skin biopsies will know well that often a first biopsy from a patient who's being considered to possibly be developing mycosis fungoides will often be quite a challenge and often not really contain diagnostic changes. Often, certainly in my experience and others as well, you might need several biopsies over a period of months before getting a confident diagnosis. And it's also a clinical pathological diagnosis. Mycosis fungoides is actually a clinical diagnosis, not a pathological diagnosis, really. We should be diagnosing an epidermotropic cutaneous T-cell lymphoma. But it shows all of the things you're supposed to see. So it's good to see a proper example now and again to remind ourselves what things really look like. Okay, let's go to slide 4. I've got a clinical photograph for you of a lump on the scalp, a firm nodular lesion on the scalp, growing fast, we were told. And we'll go and have a look at the slide. And here it is. And here there's this very dense infiltrate in the dermis. This is not actually an interface dermatitis, but it contrasts nicely with the previous case. You see there are large blastic cells as well as smaller lymphocytes infiltrating the dermis. And if I just zoom out a little bit, you can see that this is a deeply seated process. It's not actually involving the epidermis at all. The epidermis is kind of normal and the epidermis is not involved. And the biopsy has been taken through the top part of this nodule in the scalp. I'm probably pressing the wrong button. So we had a deep infiltrate with plastic cells. Immuno showed that the cells were CD20 positive as well as PAX5, CD10 and BCL6, and negative for a list of various other things, including CD3 and CD30. And a Ki67 showed a proliferation fraction of about 80%. EBA was negative, MEC was negative, BCL2 was negative, cyclin D1 and MUM1 negative. So here we see the CD20 and the Ki67. So what is this? Is it lupus vulgaris, mycosis fungoides, primary cutaneous B-cell lymphoma, diffuse large B-cell lymphoma, or Merkel cell carcinoma? Vote now, please.
Okay, we seem to have general consensus again for this one. With 10 votes so far, we've got primary cutaneous lymphoma. Second most popular was diffuse large B-cell lymphoma with 6 answers. Okay,
and in fact, that's what this was. This was somebody who was known to have a systemic nodal diffuse large B-cell lymphoma and had progression of disease. So these were cutaneous deposits of a systemic B-cell lymphoma rather than a primary cutaneous B-cell lymphoma. And in fact, I didn't give you all the information, I'll make it too easy for you, but the patient had several of these nodules growing quite rapidly. And I think one of the lessons here is in thinking about these biopsies, when you see something that's very deeply seated and nowhere near the interface, well, it takes you away from a T-cell lymphoma most of the time, not always. But then you start thinking about systemic disease. And just as we had in the second case, when there's an awful lot going on, you need to get some more information about the patient to see what's going on in the background and see whether this is a cutaneous manifestation of systemic disease. Merkel cell carcinoma I threw in because a diagnosis of Merkel cell carcinoma these days is relatively straightforward with appropriate immuno. But when it was first described, people used to say that it was difficult to tell the difference between Merkel cell carcinoma and lymphoma. But these days, I don't think we should make that mistake too often. And you wouldn't make a diagnosis of either of these conditions just on the H&E. You'd always be doing some immunohistochemistry to confirm what was going on. Okay, let's go to case number 5. This is a 26-year-old man, and he had a wide differential diagnosis. So the biopsy came with all of these possibilities written on the request form: urticarial vasculitis, Rolls syndrome, of lupus erythematosus with erythema multiforme-like lesions, subacute lupus erythematosus, mixed connective tissue disease, sweet syndrome, So let's look at the biopsy. And here it is. And you can see in this biopsy that there is hyperkeratotic scaling. There's a big something there that might actually be a plug going down into a hair follicle. The epidermis is rather thin and a bit atrophic looking. Stop. And you can see there's quite prominent basal hydropic change. If you look immediately beneath the epidermis, there's a kind of pink line that you can trace out where there are no cells. So this isn't actually an interface dermatitis because there are no lymphocytes actually going straight into the epidermis, I don't think. And then looking into the stroma, we can see lots of little bits of dust lying around. Down here, there's, I think it's a bit of a hair follicle probably, and you can see that that's got some lymphocytic infiltration around it. There's a kind of bluish blush in the background, which I think is partly due to breakdown of nuclei, and maybe there's some interstitial mucin as well. But overall, you might call this porcicellular. There aren't that many cells here. You can get an impression looking where the blue is that there's some around the superficial vessels and the deep vessels and the adnexal structures. There's a sweat gland here that's perhaps got not very many, 1 or 2, and some of this interstitial mucin. So this was a sort of not terribly dramatic appearance in the biopsy, but actually quite a lot of information to be seen there. I'm going to try pressing a different button this time. Let's go there. And so we saw, well, a little bit of lichenoid infiltration, but also a clear basement membrane zone, hyperkeratosis, some dyskeratosis. Oh no, it takes me to the wrong slide again. Scaling, atrophy, basal vacuolation change, superficial edema, porcy inflammatory cell infiltrate, nuclear dust, and I've also got in places here, for example, you can see there's a kind of eosinophilic, almost like a globule there, as well as this infiltrate around a hair follicle. And we did a PAS, and this time sort of emphasized some of those globules, and also there's a sort of rather diffuse increased PS positivity in the basement membrane zone. So, what are you going to vote for? Vote now, please.
Okay, so far 14 out of 16 now, people have voted for subacute cutaneous LE.
Okay, and that was my diagnosis as well. I think this shows all of the features of an LE biopsy. You know, classically, LE shows hyperkeratosis, follicular plugging, basal hydropic change. Immunofluorescence will show you the speckled band of immune complexes deposited in the basal membrane zone. And I think that's what we could see here. I think the PAS staining and that sort of eosinophilic layer beneath the epidermis is where the immunofluorescence will be positive. I don't have immunofluorescence on this case. It doesn't show any of the erythema multiforme-like epidermal necrosis that we might expect for a Roll syndrome. There's too much going on for it to be an urticarial vasculitis. We don't see the neutrophils of Sweet's syndrome, and it doesn't look like anything like a lymphoma. So, well done. So the last one is from a 32-year-old woman with itchy excoriated papules on the trunk and extremities for a month. And just have a look at that biopsy. So here we can see this biopsy, which I think shows a little bit of epidermal acanthosis. The keratin on the surface is still fairly basket weavy. It's not really a hyperkeratotic appearance, but the epidermis is a bit thicker than the other biopsies we've looked at today. So I think there is some acanthosis, and you can start to see little white spots between the cells because there's some spongiosis there. And I put this in particularly for you to see this lesion, which you don't see very often, and I thought you might like to see. And this is a sort of space containing cells, and this is a Potrier's abscess-like vesicle. It's probably not a Potrier's abscess because we're not looking at an epidermotropic condition. There are lymphocytes around the superficial vessels and a few lymphocytes in the interstitial stroma. And then we've got this spongiotic change in the epidermis with some acanthosis and then the Potrier-like vesicle. You know, away from there, there's acanthosis, but not very dramatic spongiosis, quite subtle changes really, and subtle superficial perivascular lymphocytic infiltration. So go back to the PowerPoint from last time. And hooray. So in some of the sections, I did see a little bit of scaling. There was acanthosis. There was this Potrier simulant spongiotic lesion and a dermal infiltrate, some edema. There we can see the lesion. And which diagnosis would you prefer? Vote now, please. How are we doing?
Yeah, it's a bit more split this time than last time. So the most popular answer with 9 is eczema. We had 2 votes for the correct answer, and then 2 for psoriasis and 1 for mycosis.
Okay, so I think that this is, I think, an example of pityriasis rosea, which overlaps really. You know, if you don't get those sort of nice vesicles, it's not a very straightforward pathological diagnosis to make because it looks quite like eczema. So I've got complete sympathy with anyone who made a diagnosis of eczema. One of the things that I would always do in a case like this is a PAS, just to make sure that there's no fungal infection, because if you've got a tinea infection, you'll often get quite prominent spongiotic change and vesicle formation in the epidermis, which can be equally confusing. So this is a clinico-pathological diagnosis. You need to know what the patient looks like, you know, what the dermatologist thought about the patient before reaching a final diagnosis. It was a bit acanthotic, but I would hesitate to support a diagnosis of psoriasis because it wasn't showing the other features of psoriasis, which can be quite variable, sometimes quite subtle. And so I think this has sort of background appearance quite like eczema, but with I think specific features that support a diagnosis of pityriasis rosea. And I think this is probably a nice example for you to see. Good, so that concludes my slides, and we can now take any questions. Laura, do we have any questions?
Yes, we've got a couple that came through during the webinar, so hopefully I've matched these to the right cases. So the first question that we've got, I think this is for slide 4. Were you able to review any previous biopsies from this patient?
Yes, and this is crucial really, because looking in the computer was the patient's lymph node biopsy, which had been thoroughly diagnosed. And so I was not only able to know about the patient's previous diagnosis, but also to compare the phenotype of this tumor with the original diagnostic material and demonstrate that it had the same immunophenotype and appearance as what had been seen in a previous lymph node biopsy.
Okay. We've actually got a second question that's come in for case 4, I think. So what is the exact must criteria for lichenoid tissue reaction? Is it interface dermatitis or basal vascular degeneration? I think it's for case 4, it doesn't say in the question, sorry.
Yeah, just say the question again, please.
What is the exact must criteria for lichenoid tissue reaction? Is it interface dermatitis, lichenoid, sorry.
Yeah.
Is it interface dermatitis or basal vascular degeneration?
Well, I think lichenoid as a description can cover a multitude of sins, all the way from lichen simplex chronicus, which is when somebody scratches their skin long enough for it to become disease to the point that the biopsy is performed. And so I think it's as I showed you in my first slide, you need to look at the whole biopsy, see what is happening on the surface. In lichen planus, it should be showing definite orthokeratotic hyperkeratosis. If you're seeing parakeratosis, that takes you into other differential diagnoses. You look at the granular cell layer, you look at the whole epidermis and the profile and see what's happening exactly. Are the lymphocytes going into the base of the epidermis? Are they attacking the basal cells? Is there pigmentary incontinence? What's the nature of the infiltrate? Are there eosinophils and so forth? So I think you have to put the whole thing together. I don't think you can point at one thing to just come to a conclusion.
Okay, we've got a couple more that have just come in. So I think this is for case 5. Did you see any, did you do any other special stains on this biopsy?
I think we did a PAS. We didn't have the opportunity of doing immunofluorescence, which would have really helped to clinch the diagnosis. But I think the person looking after the patient had, the full information about the various other studies that have been performed.
Perfect. And then we've got another one for case 2. Did you consider cutaneous metastasis or melanoma as a diagnosis?
Cutaneous metastatic melanoma. Yeah, well, I think you always have to consider melanoma because it can present in so many different ways. And we called this Paraneoplastic Pemphigus on the basis that we weren't expecting to see primary tumor cells in the infiltrate, and there was actually no evidence of them there. But we did consider that and look to see if we could see any, carcinoma cells in there, but there was nothing stainable with cytokeratin and no melanoma cells. But always think of melanoma when you can't think what you're looking at. Could be melanoma.
Okay, and the last question that we've got is for case 3. Could this be large plaque parapsoriasis?
That's a good question. Well, probably not in this example, partly because of the clinical history. I told you that the patient had a 12-year history of mycosis fungoides, but there is an overlap between large plaque parapsoriasis and early mycosis fungoides, and it can be often difficult to tell the difference. And I think anybody who has a biopsy diagnosis of large plaque parapsoriasis, probably that's not the end of the matter. They need to be followed to see if that stays as the diagnosis or if it responds to treatment, or if the disease progresses, then you have to be thinking about whether in fact this might be progressing to mycosis fungoides.
Oh, sorry, we've actually had another question that's come in that we've missed. So case 4, can you differentiate primary versus diffuse large cell lymphoma by any other means if history is not available?
Yes, I think the way you do that is by referring to a hematopathologist. And I think I discussed this with my expert colleague on hematopathology. I think in the subclassification of lymphomas, we've got hematopathologists around, and that's what we're there for. So I think the dermatopathologist has to work with the hematopathologist when classifying and diagnosing these lymphomas.
Perfect. Well, thank you, Dr. Nigel. We haven't got any other questions, so I'd like to thank you very much for your time. We've got a short survey as well, just to get feedback on the webinar that if people can please complete, we'd be really grateful. It'll just help us with future webinars. But Dr. Nigel, thank you very much. It was a very insightful and interesting presentation.
And thank you all for coming.